Good morning, everyone. Thank you for joining today's edition of the COVID-19 Weekly Update with VDH Central Office and Local Health Districts. Today is January 22nd, 2021. The meeting should run between 11 a.m. and 12:30 p.m. We may end a little bit early depending upon content. Just a reminder, you will be muted upon entry. Please refrain from unmuting yourself during the call. This call will be recorded. Please type any questions for presenters in the chat box or email them to donald.moore@vdh.virginia.gov with the subject line LHD call question. Looking at today's agenda, we'll start off with the VAMS update. We'll have information from the vaccination unit, other PH ops that include health information, investigation, surveillance, containment, and informatics and information systems. We'll also have an update from DCLS, as well as a modeling update, a testing update, and then time for questions in the chat box at the end of the session. So we'll go ahead and get started off with the VAMS updates with Bob Moskoff and Susie Silverstein. Bob, can you please take the call?
Can you hear me, James?
I can, sir. Please go ahead.
I just wanted to give you an update on an effort that is at the governor's level down through the secretary for us to invoke. The effort is to establish a mass vaccination capability across the Commonwealth. Obviously, there is a lot of large vaccination ongoing within the local health districts and with jurisdictions and in some of the healthcare facilities. What we're looking at is the established 10 to 12 large sites, might be the same sites that local health districts are working on right now across the Commonwealth, and to staff them with at the admin log group, the National Guard. The National Guard will be available on or about the 1st of February for deployment of a 200 to 250 person group. So we're looking at divvying them up among the districts to support ongoing vaccination, mass vaccination efforts, and then eventually slide to when more vaccine becomes available into this larger mass vaccination effort. This will be centrally coordinated, but it will be implemented on the locally and regionally. This is a whole of government efforts. So the Department of Emergency Management has established an incident management team to help coordinate this. We are working with VDH regional coordinators, VDEM chief regional coordinators, healthcare coalitions to identify sites, to identify staff, whether they're Medical Reserve Corps for vaccination beyond the Guard, which I already mentioned for admin log, but MRC, nurses from the nursing programs, as well as the community college nursing programs and schools of nursing, contract nursing. In fact, the incident management team has already reached out to a lot of the contractors that will have these available once the vaccine is more free flowing and we can provide boluses of vaccine to these sites. So we're developing based on staffing models and plans that we receive from some of the local health districts. We're developing staffing models for this. We're developing programs. We're doing site selection. The IMT is going out to look at site selection as early as next week. My counterpart on VDEM, which is Deputy State Coordinator Aaron Sutton, used to be the Virginia Beach Health District planner, and subsequent to that, the emergency manager in Virginia Beach. She and I will be on the road observing some of the ongoing efforts, which are looking really good, by the way, and getting best practices, collecting best practices. In fact, VDEM's got a group called the Olson Group, which will be helping best practices so that when we roll this thing out, and as you've heard so many times, when the vaccine is available, and we know that's probably not going to be the case until at least March. So in preparation for that, what we're calling a warm implementation or a soft transition, we're going to be reaching out through Bob Hicks and the CHS group and to the local health districts through CHS to identify those locations where we can deploy the Guard to assist in your efforts now and then, as I said, transition later. Take any questions that you might have. I just wanted to give you an update on what we're looking at.
Hey, Colonel Moskoff, this is Steve Herring, Alexandria.
Dr. Herring.
Good morning. Thanks for this update. As a VANG come to our pods to help us, what will happen when the larger regional pods open? What I'm wondering is part of this to help us temporarily and to train VANG in how pods work, which I think is a good thing. But then later, as they're redeployed to the large regional, I'm presuming we would lose that support at that time.
I don't think that's a good assumption, Steve. I think as we go forward and look at how we're transitioning, some of the pods that are being established right now will indeed be the pods, will become the pods. We'll help the staffing of them. We'll be using some resources that are already being employed there. VDEM will work with local emergency managers in some cases. We're not going to throw any babies out with the bathwater. We're going to look at what's there, and we're going to go case by case. We're going to coordinate with you all the way, and determine the best way to roll this thing out.
Okay, that's helpful. I just that either way I'm fine with, whether it's temporary help that relieves us, over the next 4 weeks, or if it's something that we can depend on over the coming months.
It will be. It will continue. That's the ground truth. It will continue for the foreseeable future. The TAG, the Adjutant General of the Guard, announced to us yesterday that he's standing up a vaccination task force, initially at about 200, 250 folks, and they're on for the duration of our campaign.
Very helpful. Thank you.
Sure. Anything else, James? Any chat stuff?
Nothing coming through in chat. And just a reminder that please keep comments and questions to the chat box to allow us to get through the session as promptly as possible. Anything else from you, Bob?
Just reiterate that we will continue to keep all of you updated through the forums, through these weekly meetings. And again, that we're working very closely with VDEM and through VDEM with your counterparts. But again, there's going to be no siloing. We're going to keep everybody engaged at the same time and do real-time situational awareness.
Thank you. Any comments from Susie Silverstein today?
I don't think Susie's going to be on.
All right, thank you. So next up, we'll move to the vaccination update with Marshall Vogt. Marshall, can you please take the call?
Good morning, everybody. If we can go to the next slide, I've got a few agenda items and then we'll dig down into it. I'm going to be talking today a little bit about the pre-registration data that has been collected from the Jebbit Tool on the VDH website, entry of doses administered data into VIIS, updates on VAMS, and then also updates on the PrepMod transition, moving from VAMS to PrepMod, and then some additional information about the Federal Pharmacy Partnership for Long-Term Care Facilities. So if we go to the next slide, talking just a little bit about pre-registration data from the Jebbit tool. As you are probably aware, VDH used a tool called Jebbit, which is almost a choose-your-own-adventure kind of quiz that allows you to enter information about yourself, and it was basically telling you where you fell out in the priority groups for vaccination. It was also collecting user information for contacting individuals who completed this survey. And so I think a lot of people got an email and it said basically if you completed this that you were pre-registered in the system. What we realized is that we were collecting a lot of this information, but that it really needed to get out to the districts because districts were possibly collecting ways to pre-register people for vaccine or start a list of people that were interested, and we're reaching out to those people in a targeted fashion for phase 1A and 1B vaccination. So what we did is we downloaded that information that the Jebbit tool collected, and we've sent that out to the districts to allow you to outreach to those phase 1A and 1B eligible individuals. And it may be as simple as just acknowledging that they have completed that survey and that more vaccination opportunities are coming soon. It may be more targeted outreach to individuals if you have clinics that you're available to provide right now. What we want to do, though, is not continue to collect that information through the Jebbit tool. So starting a couple days ago, we kind of transformed the Jebbit tool. It will still tell you what your priority group or phase eligibility is, but it's not going to be collecting that information any longer. Instead, our goal is to transform the VDH website and to really use that to drive people to determine what phase they're in terms of vaccine eligibility, and then connect them to their district website or a district contact person so that they can discuss options or view options for vaccine clinics. Basically, this is still a little bit of a work in progress. We're kind of in the middle of it. I will say the ultimate goal is to have PrepMod, where you can basically go and type in your zip code and find a clinic near you. And the VAMS system works very similarly to this, but of course, we're running into the issue now where clinics are kind of overwhelmed. Of course, PrepMod is going to have the public-facing open clinics as well as the ability to have closed clinics. But the too long do not read of this is that we have tweaked the Jebbit tool a little bit, but any data that was gathered from that Jebbit tool for pre-registration is available for districts to use. If we move to the next slide, I want to shift and talk a little bit now about entry of doses administered data into VIIS. As you're aware, anything that you enter into VAMS, either through a regular clinic or a third-party clinic, should be flowing into the VIIS system automatically. We have had a few limited instances where clinics in the VAMS system did not have the right org codes on them to feed that data into the VIIS system automatically. We have addressed those issues, and the data should be flowing now. However, if you have used paper forms, those need to be entered either through VAMS or into VIIS. If you want to enter them through VAMS, you can enter them retrospectively using a third-party clinic, but the only wrinkle is that the provider that administered the vaccine has to be the provider who enters that paper vaccination record into VAMS. It's a limitation of the system, and we're hopeful that in future releases of VAMS, a data entry role will be able to accomplish that. Unfortunately, we're not going to be on VAMS too much longer, so I can't tell you if that capability will roll out while we're still using VAMS. The other option is to enter that information directly into VIIS. That allows retrospective data entry by either the provider or the designee. The bottom line, though, is that if you have doses administered that have been recorded on paper forms, please enter them as soon as possible. Repeating, if you have doses administered that have been recorded on paper forms and they have not been entered into VAMS or VIIS, please enter them as soon as possible. We want to make sure that the data that we are reporting out is accurate, and we need those doses in VIIS in order to ensure that that data is accurate and as up-to-date as possible. If you need help entering those doses administered into VIIS, please contact Bill Edmonds. He can connect you to some data entry training or actual support. And please remember, too, that this is not a medical record system, so you do need to retain those vaccination records as a medical record. If we move to the next slide, some updates on the VAMS system, if you are still using that for your clinics and for entering information. There was a new release that came out, version 1.1. Templates were part of that release. So please look for the newest versions of those templates on our internal website there. You'll know that they are the newest versions because they will say version 1.1 at the top of the template. They look exactly similar in terms of the layout of the columns and all that kind of stuff, but they are functionally different. So please remember to use the latest and greatest templates, and you can continue to send those to charlesjones@vdh.virginia.gov. And again, my thanks to Charles. He's very responsive and has been working very hard to get those into the system. As always, please pay attention to the formatting and validation. especially those fields that are required. And as I mentioned in the previous slide, in order to make sure that your data is going into the VIIS system without any errors, please use your correct VTRAX PIN and VIS org ID. And those are available on a sheet that is where you can find the templates for downloading as well. Another tip, as you're naming clinics, I would encourage you to include which vaccine types are available, Moderna or Pfizer or both, so that when we're trying to connect second dose recipients to clinics, they can be sure that they have the right vaccine available to them. A few final reminders on VAMS if we go to the next slide. The recent release had some additional functionality, built into it, including search functionality that is now fully operable. As all of you know, there were some issues with search functionality in VAMS for quite a while, and so if you need to find people now, it's a lot easier to use that search functionality. They're going to continue to enhance that as you will be able to search across different portals in VAMS, I believe, but it's a lot better than it was. Automatic reminder emails will be sent to organization and employer point of contacts that have not yet registered. So if you're sending us that list of employer organization point of contacts and they get that email but they don't register, it's going to trigger off automatic email reminders for a period of time. Please continue to tell people to search their spam folders, search their junk folders, their promotions tab in Gmail, or to work with their IT department if that email might have been filtered. VAMS is sending these emails to folks, and we know that some people are having trouble finding them. If that still doesn't work, have them try to use an alternate email address, and Charles and I can work with you on that. There have been some additional enhancements, including increased validation requirements for inventory logging. Basically, if you get an issue, an error message with your inventory, there are going to be instructions that come with that error message that will tell you how to fix that issue. And they have made some enhancements to clinic operating hours and treatment station hours. Basically, edits to those hours could cause every clinic using those particular hours, if they're changed, to throw out recipient appointments. And to reduce that risk, when you make edits to any kind of treatment or operating station hours or clinic hours, it's going to show a table where all of those, for all of the clinics where those hours are used. So basically, it's hopefully going to really help cut down on, if you change any hours for clinic operating hours or treatment operating station hours, those changes impacting other clinics. If we go to the next slide, I'll start talking a little bit more about PrepMod, which of course is the system that we are shifting to replace VAMS. PrepMod is now live. You see with the implementation timeline, we have some districts that are in the pilot process, and then we're bringing districts in across different waves. I apologize, the text on this slide is a little small, but that gives you an actual timeline across the next couple of weeks where PrepMod is going to be brought online. Remember, this system is, we think, a little bit better than VAMS in the sense that we have more functionality for how to customize the system. The assignment of users and creation of clinics in the system is something that can really be done at the district level. And there is the capability to do both open and closed point of dispensing clinics in PrepMod. We know PrepMod is not perfect. It too is continuing to be enhanced, and I'm happy to report that I heard yesterday that there are going to be some enhancements to closed point of dispensing clinics in PrepMod to really kind of lock them down a little bit more and prevent sharing of clinic links among people. We've seen that happen with some of the scheduling systems. We know that that happens with VAMS in the sense that you can't really lock them down. It's a little bit like the Wild West. We think PrepMod, it has better functionality now, but will continue to have enhanced functionality. And we've been working very closely with the developers. If we go to the next slide, I'll just show you really briefly kind of the timetable for various districts to come on board for PrepMod. You can see the pilot districts there went live yesterday. The next wave of districts will be going live on the 25th, which is this coming Monday. And then we're going to be bringing the final two groups on board February 1st and February 8th. Now, the system is live, so if you do want to accelerate or decelerate which wave you're in, please reach out to Bill Edmonds, and he and his team will try as best as possible to accommodate you. We do want to get this tool out as quickly as possible and make it available as quickly as possible to individuals, but we also want to do this in kind of a staged, a wave process so that we're able to better support districts as they're coming on board, and also learn from districts what's working, what's not working, and continue to update our training materials and all of our user guidance. If we go to the final slide here on PrepMod, you can see resources have been made available. My thanks to Bill, Sue Skidmore, and Nitin. They really represent the core of the PrepMod team with assistance from others such as Jesse Silver and our pilot districts. These resources have been sent out to kind of the designated points of contact for the PrepMod system across the districts. And if we go to the next slide, there's some contact information for the PrepMod team. So if you have questions about PrepMod, please reach out to Sue, Nitin, and Bill. If you have questions about VAMS, I will continue to take those with Charles and Dale Thomas as my backup. And of course, Charles will continue to be your main point of contact for uploading your clinics and your employers and organizations. As we work to shift from VAMS to PrepMod, that's something that's really going to be discussed as you start to get more details on PrepMod and you enter into your particular wave of PrepMod onboarding, but we're hoping to do as clean a transition as possible between the two systems. So we're encouraging people to plan to finish up anybody that you've started vaccinating with VAMS and then to start other clinics in PrepMod, and then we'll switch over to the PrepMod system. I'm going to shift now into a couple final updates for the Pharmacy Partnership for Long-Term Care Facilities, and that will be the end of my update. So these slides are from Mike Magner and the HAI team who's been working with long-term care facility coordination. My thanks to them for sending these to me. Just reporting out that as of yesterday, over 52,000 doses of COVID-19 vaccine have been provided to staff and residents of long-term care facilities. 280 of 287 skilled nursing facilities have completed their first round of vaccination visits, and those remaining 7 will have their first round visits completed by the 28th of this month. 17 of second dose clinics will be completed, or were completed rather, as of yesterday. Part B of this program, which is for assisted living facilities and other facilities that are not skilled nursing facilities, began on January 11th. And you can see that 336 of over 1,100 of these facilities completed their first dose clinics already. So as we're getting additional allocation, we're trying to finish up the skilled nursing facilities and then immediately turn around and start vaccinating staff and residents in these other facilities. On the next slide, you'll see some of the issues that we've been facing. There have been some scheduling issues in terms of facilities not having dates for their first dose clinics, and some of those clinic events not being scheduled until mid-February or later. We are working with CDS and Walgreens, who are of course the two pharmacies that are coordinating this program and administering the vaccine, to try to expedite scheduling. And we may be able to shift some workload to other providers if CDS and Walgreens are not able to accommodate this enhanced scheduling. There's some issues with real world numbers versus numbers in Tiberius, which is one of our planning systems that gives us kind of population estimates versus VIIS in terms of our numbers and vaccine doses allocated, ordered, shipped, delivered, all matching up. We're working to make sure that those are correct. And we're also making sure to try to verify that all doses administered are being entered into VIIS so that we're counting those as part of our program. And then, of course, I think some issues around messaging and expectations. Phase 1B started in most districts before all long-term care facilities had their first dose clinics. And I think some confusion about Phase 1A, Part A, Part B, and we're working to improve that messaging. Finally, there were some long-term care facilities that were not included in the CDC program, and on the next slide here, we'll discuss the best way to manage those. So all skilled nursing facilities and assisted living facilities were automatically opted in by the Virginia Department of Health into this program. Some were opted in late, and that has delayed some scheduling. But there are other facilities that were not opted in, and these include independent facilities, HUD senior living facilities, group homes, those sorts of things. If these facilities are not covered by that federal program, they need to coordinate with local health districts or other private vaccine providers. When it comes to DVHDS regulated group homes, VDH and DVHDS are working with the with Family Care Pharmacy to vaccinate those staff and residents not covered by that CDC partnership. So please continue to work with Mike and his team if you have questions about how to connect to these facilities that are not part of that federal pharmacy partnership program, or if you're having issues with that federal pharmacy partnership program. On the next slide, again, just wanted to say thank you so much. Bernie Sanders is waiting on my front lawn for his second dose of vaccine, so I need to go deal with him right now. And with that, I'll turn the call back over to James.
Thank you, Marshall, for the update. Next up, we'll tap into other public health ops, including health information, investigation, surveillance, containment, and informatics and information systems with Dawn Sadie. Dawn, please take the call.
Hi, James. This is Dawn. If you want to shift to the next slide, I'll get started with the health information update. Thank you. To support the vaccine unit, the health information team is continuing to update the vaccine FAQs on a weekly basis. The updated FAQs were posted on Thursday and include these new questions indicated here under that first sub-bullet. The team also drafted new content for a one-page fact sheet to explain vaccine effectiveness, and CITL will be working on the graphics for that. The team continues to work with CITL and others to review fact sheets, flyers, social media content, and other resources. In other news, the health information team is also reviewing the 14 websites that they maintain to try and consolidate and streamline information and improve overall readability. And they plan to complete that project around February the 1st. And the health information team has previously been posting the testing team's list of commercial labs performing SARS-CoV testing on the intranet and external website. And the testing team recently discontinued that list. The latest version from the 11th of January is still posted on the sites, but a note has been added that future updates are not anticipated. Next slide. Okay, moving on to investigations and HAI. This slide just shows the number of outbreaks reported from long-term care facilities each week since the start of the pandemic. And each of the 5 health planning regions is represented by a different color. What we've seen generally is that when transmission increases in the community, the virus is also introduced into facilities, and the number of long-term care facilities outbreaks increases. You can see the long-term care outbreaks in the regions has shifted somewhat over time. In December, the highest proportion of reported outbreaks in long-term care facilities occurred in the central region at 26%, followed by Northwest at 24%. And Eastern and Northern regions both had 19% respectively, and then the Southwest at 12%. Next slide. Okay, an update on the TelelCAR process. The HAI teams created a REDCap survey to manage requests coming in to perform remote infection prevention and control assessments, or TelelCARs, with facilities. The districts can use the REDCap survey link to request a TelelCAR on behalf of a facility. The link is included in the notification emails that are sent to districts when a nursing home has been identified as a hotspot. And hotspots are 10 or more new resident cases reported to NHSN in a reporting week. The team is prioritizing requests based on the facility type, outbreak status, whether they've had a recent visit, and team capacity. And they are working very hard to add additional staff to help expand that capacity. We just ask if you can refrain from sharing the link for the TelelCAR request outside of VDH until we notify you that capacity has increased. And once that happens, we'll distribute the link more widely, including to facilities who would be able to directly request assistance. We also wanted to note that we're tracking nursing homes from week to week when we receive the weekly hotspot list based on cases reported in the past week. And some nursing homes are being identified as hotspots for multiple weeks. If a facility is a repeat on the hotspot list and hasn't had a recent visit, the team will send an email to the local health district and offer an ICAR with the facility. If the facility has had a previous tele-ICAR, the team will work to schedule a follow-up call with the facility. Next slide. Okay, this is an update about guidance following vaccination. We know that you all are getting lots of questions about this, and there's an increased interest in it. The team did check in with CDC this week and shared questions that we've been receiving from facilities and local health districts about guidance in long-term care facilities once residents and staff have received 2 doses of vaccine. At this time, the recommendation is to continue to follow all preventive measures and recommendations to reduce transmission in nursing homes. Current guidance around testing and visitation have not yet been modified because the vaccines within FDA EUA have primarily been shown to decrease incidence of symptomatic disease, but their effect on transmission and asymptomatic infection are less clear. CDC is working very hard to better understand the effect of vaccines on preventing infection and transmission before modifying any recommendations about IPC measures, testing, or quarantine, and they're also in active discussions with CMS. There are updates planned over the coming weeks, and we promise to communicate that information to local health districts as soon as we know. You'll know. Thank you. Next slide. Okay, this is an update about point of care testing and test reporting. On January 8th, HHS updated their reporting guidance for CARES Act to state that NHSN's point of care test reporting tool is the preferred but not required method for CMS certified long-term care facilities to submit test results to state health departments and HHS. On January 8th, CMS also released a memo with this update. So CMS certified nursing homes can either use NHSN or the VDH portal to report results. They only need to report results into one system because results reported into NHSN will be sent to local health districts via ELR or HL7 and imported into VEDS. So facilities should, of course, report point of care test results, both positive and negative, within 24 hours, regardless of the system that's used. And they can refer to the point of care testing reporting tool, FAQs, for more information if that's needed. Just a quick note that NHSN does only allow reporting of test results for residents and staff. Reporting for visitors is not accepted into NHSN, so result reporting for visitors should be submitted to the VDH portal. And also just a reminder that assisted living facilities and other long-term care facilities not reporting into NHSN should continue to use the VDH portal. The Long-Term Care Task Force website was updated yesterday with all of this information. If you click on the Testing Guidance for Long-Term Care Facilities tab, we're also planning an upcoming long-term care specific clinician letter that will include information about point of care testing. Okay, next slide, please. Some other updates. OLC learned this week that the process for surveys in acute care hospitals is changing for the time being due to the current surge. Routine surveys are suspended for at least 30 days. And there's a link here to the CMS memo if you would like additional details. Regarding quarantine of healthcare personnel, we wanted to note the current VDH and CDC guidance about quarantine of healthcare personnel. It was posted on December 15th, noting that the 14-day quarantine of healthcare personnel is preferred and is the safest option. However, we do want to recognize that flexibility is needed at this point because many facilities are experiencing staffing shortages. We have heard from some nursing homes that communication from local health districts was that healthcare providers who are asymptomatic couldn't return to work before the end of the 14-day period. So we just wanted to point out that details are outlined in this document, that there are options for ending quarantine after day 10 or after day 7 with a negative viral test for facilities that need to implement that option if there are staffing shortages. And regarding that document, we are updating it to also include details on isolation for positive healthcare workers so that everything is in one document. And we hope that that will be posted within the next few days. In the meantime, if you have any questions or want to discuss specific situations, please reach out to the HAI mailbox at hai@vdh.virginia.gov. Okay, next slide. Our surveillance updates here, to start with an update on Essence. Essence is being used to conduct surveillance for severe vaccine adverse events in collaboration with the Division of Immunization. If warranted, outreach to a facility through the local health district may be requested to encourage reporting to the CDC Vaccine Adverse Event Reporting System. COVID-related visits to EDs and urgent cares decreased in all 5 health regions last week, and that's the first time that we've seen a decrease in the percent of COVID-related visits statewide since mid-October. COVID-related visits decreased among EDs by 11% when compared to the previous week, and among urgent cares by 12%. However, just to note that a substantial burden does continue to be placed on healthcare facilities, with almost 1/3 of all visits reporting to Essence last week being related to COVID. Next slide. It's just an update on our outbreak surveillance. There have been over 2,100 confirmed outbreaks created in VAMS, 37% in long-term care facilities, 22% in business and workplaces, and 13% in educational settings. Next slide. This is the number of confirmed outbreaks by month and exposure setting, and the data for January are current as of the 20th. There's an increase in the percentage of outbreaks reported in long-term care facilities in December, and so far for January, we're seeing that same trend, with long-term care facilities making up 41% of all outbreaks that are entered into the outbreak system. Next slide. This shows the number of outbreaks by week. For last week, the last complete reporting week, January 10th through the 16th, there were 74 confirmed outbreaks reported in VAS. The most were reported from the central region, with 26 outbreaks reported, followed by 17 in northern, 12 in eastern, 11 in southwest, and 8 reported in northwest. Next slide. Okay, we've got a number of updates on COVIDWISE. So there's some changes that are set to launch on Tuesday, January 26th. Virginia is going to be turning on COVIDWISE Express. This it's a lightweight exposure notification that is an app-less technology for iPhone users. It allows them to activate exposure notifications without an app. When COVIDWISE is turned on, a push notification will go out to all iPhone users that don't already have COVIDWISE installed on their phone. However, Android users and iPhone users who already have the app can continue to use COVIDWISE, because that app actually still offers more features such as stats, a virtual agent, and the ability to report a positive test. Next slide. The additional new app updates will include some enhanced messaging and graphics when an exposure notification is received, a new voluntary option to report symptom onset after a positive test report, and updated responses in the virtual agent that include vaccination resource links. Next slide. This is kind of important. Also beginning on Tuesday, January 26th, VDH will begin sending a series of text messages to people who receive a positive COVID-19 viral test and have a valid mobile phone number. The text messages will help provide rapid notification and encourage anyone who's tested positive to stay home and away from other people. The message will also provide a link to the new COVIDWISE Verification Code Portal and link back to the VDH website for more information. The text messages will come from the number in red that's shown on the slide, and we'll use Twilio, and the messages will be sent between 8 a.m. and 8 p.m. daily. And then the last text message, the fourth and final one, prompts the person to respond with a 1 to receive the messages in Spanish. Next slide. The COVIDWISE Verification Portal will allow people who've tested positive to obtain a self-verification code to anonymously submit their test result through COVIDWISE. That responsibility was previously on the VDH case investigators, but now individuals can do it themselves. The portal has a brief public health messaging and COVIDWISE information and links back to the VDH if you are sick page. When the individual goes to the portal, they'll enter their last name, date of birth, and test date they use to register for the test to ensure that only valid positive COVID-19 cases are reported in COVIDWISE. Next slide. The user then has the ability to either send a link with the embedded code directly to their cell phone, which reports directly in the app, or they can generate a code within the portal and copy and paste it into the app. Next slide. Once the portal launches and the app updates, the COVIDWISE pins in VEDS should no longer be provided to the case by case investigators. The verification code will actually move to 8 digits, so the 6-digit code in VEDS will no longer work. And that part will be phased out, as will the question in VEDS asking, was a COVIDWISE pin provided? The case investigator should encourage patients to use the portal, which can be accessed through the VDH website. We do still want to encourage, particularly the contact tracers, to speak with contacts about COVIDWISE and promote use and download or enabling of COVIDWISE Express. And of course, someone who is exposed could certainly be exposed again. So it's important to use that touch point as an opportunity to provide education about COVIDWISE. And then finally, in addition to sharing the information here, we also have a press release scheduled and updates to the website and FAQs, some social media posts prepared, and have briefed the call center team on the changes. So let the containment team know, however else you all need to be supported. Okay, last slide. Thank you. This is an update from the Informatics and Information Systems team. The VEDS auto creation of investigations has been in place for more than a week. And as we previously noted, the team is using a phased approach with different improvements implemented over time. On the 20th, the logic was tweaked to associate PCR positive results with existing probable investigations, if one exists, and also implemented the population of investigation patient county from available patient zip code, and that's occurring nightly at 6:15 p.m. And then we're hoping to geocode COVID investigations beginning sometime in February. Server and application upgrades are also being planned and tentatively targeting Saturday, January 30th for an upgrade. When the upgrade is confirmed, we'll email the VEDS community, and the application will feature enhancements and hopefully improve system performance. There's also a plan to make COVID-19 vaccinations available for manual entry into the system when we upgrade, and then we'll hide the VEDS COVIDWISE fields on the 30th. Then finally, on the contact tracing side, the new SARA alert release is planned for this coming Tuesday, the 26th, and will include being able to search on values in the close contact of a known case field. And that's all from us. Thanks for your patience as we work through that. Back to you.
Thank you for the update, Dawn. Next up will be the DCLS update with Marilyn Freeman and Colleen Courtney. Can one of you please take the call?
Hi, this is Dr. Courtney. Can you hear me?
We can. Please go ahead.
Okay, next slide. This is just our intro slide, so we can go to the next one. So this is our DCLS week at a glance. We performed over 4,550 RT-PCR tests, only 2 serology tests. Over 12,660 kits were shipped, 36,288 media tubes, 3,000 swabs. To date for the year, for the new 2021, over 10,000 SARS-CoV-2 PCR tests have been performed here at the lab. We also have our additional OneLab capacity, which I'll talk about more later. So one of the things we've been keeping very busy with both last week and continuing into this week is doing same-day priority testing for the Virginia National Guard. So this was in preparation for the inauguration, and now we are helping with them to deploy, I think, out of the area as well. And so we reported over 2,400 specimens for same-day testing and are continuing that support. Another big highlight for us, we had third-party data entry that began on this last Wednesday on 1/20. And so this basically will take some of the manual data entry and submission off of the staff here and goes to a contract company. One of the feedback pieces that we got from the contract company was that a lot of the groups that are submitting are not using our most up-to-date test submission form. So we are just putting a plug out to everyone. We do have an updated test rec and test submission form. It is purple. If people have noticed, we tried to change the color to differentiate. It also has an area to put vaccine status, and we could be able to track that if people were using the new form. And it's just easier for both our staff and the third-party data entry to use a consistent form, as I'm sure you have with forms that you work with as well. So obviously we prefer that people use the DCLS Connect portal and have no paper form for sample submission and result retrieval, but we know that that's not an option for everyone. Next slide. So this is just the week view that I present every week of the scheduled versus received. You can see we did not receive very much on Sunday or Monday. We are somewhat sticking to what's scheduled versus received, but still receiving lower than what's scheduled. So just encouraging people to utilize the capacity of the lab. We are here for you, and also our OneLab partner. Next slide. So I was asked to start kind of including some sequencing updates in light of all the variants and the sequencing efforts. So far, DCLS has sequenced 139 COVID isolates. This is from 192 outbreaks. 159 of those had multiple patient samples sequenced, and 50 of those outbreaks indicated multiple introductions. So that was really kind of, what most people were interested in prior to the emergence of these very popular variants. And we now, as well as before with our previous sequences, but now we are very much actively looking for known variants, including the B117, which is also known as the UK variant, B1351, the South African variant, and also P1 and L452R. If you are looking for more information about the variant, I have the link here. We're prioritizing testing on samples with the S gene failure, but we are also sequencing from selections of outbreaks as well, so not just S gene dropouts. Currently, we have not found any sequencing data from DCLS that indicates B117 in any of the Virginia residents that we've tested. We are working, we mentioned on the call last week and had some interest in a curated slide set to distribute to local health departments to introduce sequencing, the importance of sequencing, how to submit samples, and how to utilize the results. So I'm actually working on that. We have a lot of slides that I'm digging through, and I will get that to the appropriate people to distribute. Next slide. So also, because so much is happening with OneLab, we broke this out into its own slide for this week. Just for those of you who aren't familiar with the Virginia OneLab and the DCLS OneLab, we have several partners that include Virginia Medical Center, Virginia Tech, Centera Norfolk, and Fairfax County, as well as DCLS. And the goal is to provide, an increased test capacity within the health region for community testing events and also point prevalence surveys. It also provides us a way to, work with partners, ensure quality of testing, ensure resources are distributed, and allow us to divert and support even more testing for VDH. We had a total of 42 testing events with OneLab partners, and so far to date, over 28,000 specimens have been tested through the OneLab partnership. We have additional health districts being added. Mount Rogers region began routine submissions to Virginia Tech, and we're working to add 2 additional health districts to the Virginia Tech OneLab route. We're also coordinating a pilot route submission from UVA directly to the OneLab district in the Northwest region. So a lot of different pieces moving in OneLab, getting dedicated routes, getting dedicated submissions. So really excited about the increased capacity and our new partners. Next slide. As always, this is our contact information. Terry Harper for sample support, Latoya Griffin-Thomas for scheduling of testing, Emily Hopkins for any IT or DCLS Connect portal. And then I also added both my email and the Deputy Director, Dr. Marilyn Bibbs Freeman, if you needed our information, and our general information if you had any questions. And I will be able to answer questions in the chat. Thank you.
Thank you for that update. Next up, we'll have the modeling update with Justin Crow. Justin, please take the call.
Great, thank you, James. Go ahead to the next slide, please. Just our usual background. The model continues to be improved every week as we get more data and research becomes available. Next slide, please. Just some background on the environment nationally. Nationally, we are beginning to see cases decline a bit, particularly in the Midwest where we hit our highest peaks earlier. This has been a sustained decline now, or plateau, I guess I should say, after the holidays. So it seems to be continuing past the kind of wonky holiday data that we had there for a bit. We continue to see hotspots, of course, in the South, the Northeast, and then on the West Coast, particularly in California and different areas. Next slide, please. A little closer to home, we're seeing kind of the same thing. Those states that had the high case rates previously, we're beginning to see declines or plateaus. These, again, have been sustained after the holidays. The caveat to that is we do continue to see high test positivity rates in some of our neighboring states, particularly Kentucky, Tennessee, and North Carolina. Cases continue to climb, however, in Virginia. We're at 72.2 per 100,000 as of January 19th. We have now exceeded the national average as the national cases begin to plateau and decline. They're at 54 per 100K per week. So Virginia is one of those hot spots right now. Next slide, please. Statewide, we kind of see a similar pattern. Those areas in the Southwest and to a lesser degree in Northwest Virginia, where we used to see really high case levels, are beginning to plateau or even decline a little bit. And we're seeing the highest caseloads move to Southern Virginia and a little bit into Central Virginia. That pattern might continue. We might continue to see cases kind of move east and north a bit. 89% of counties have more than 40 cases per 100,000, and 18% have more than 100 cases per 100,000. So definitely some high case loads at the local level. Next slide, please. And similar pattern where we're seeing our surges in growth, so confirming kind of what we're seeing in the data overall, as we're seeing cases grow in different patterns. Currently, there are 24 local health districts and growth patterns. That includes 13 in surge. Again, that's Southside Virginia, Fairfax and Northern Virginia, which is always concerning. And then some in Eastern Virginia, the Three Rivers area, as well as Central Virginia. Next slide, please. And we see the same pattern in our reproductive rate, transmission rates statewide. We're still above 1. The Northwest and the far Southwest Virginia areas have dipped below 1. Below 1, transmission rates below 1, but other areas, Central, Eastern, near Southwest and Northern, are all above 1, and in some cases substantially above 1. Next slide, please. Our days from onset to diagnosis continues to follow the pattern. December, we're still in that preliminary phase, but it seems to be settling in at around 4.1, 4.2 days between onset and diagnosis, which is down from what we saw in November. We'll begin having good January information here shortly. Next slide, please. I left this chart in here. There's not too much of a change except for the CDC released a modeling study looking at specifically the B117 variant that was first identified in the UK. And with what little information we have on where it's kind of seeding where it exists now, they did a modeling study, and that kind of showed that that variant should become, or they estimate it will become the predominant variant in the U.S. By March. So the risk associated with variants was moved up a little bit compared to previous slides or previous weeks. Next slide, please. Of course, getting into the modeling itself, the scenarios we looked at, we continue with the same 3 we had last week. The adaptive scenario, which is the current course paired with an optimistic vaccine schedule. Our fatigued, or kind of our worst case scenario, which is people start loosening up on their prevention efforts, and it's paired with a pessimistic vaccine schedule. And then our kind of best case scenario, so we have an optimistic vaccine schedule and people maintain or increase their prevention efforts. They continue to publish the counterfactuals with the no vaccine as sort of a comparison. I don't really talk about those too much because it's not what we're expecting. We will have the vaccine rolling out, but those are available if you want to check those. Next slide, please. We do have one new scenario, and that is a novel variant scenario. Of course, there are the UK variant has been identified in 20 states as of yesterday. There are several other variants being identified internationally, and then I think a few in California that people are beginning to take notice of. So this scenario looks at different studies that are available out there. That CDC report that model that I discussed that shows the UK variant becoming predominant by March. Other studies kind of estimate the increase in transmission to be between 30 and 55%, which is it depends really on the environment and the situation. But the UVA team has pulled that data together to create this new variant scenario. Current projected transmissibility increases gradually over 2 months to the 40% transmissible level. Of course, this will continue to be updated as more research becomes available, more data on the spread and the existence of both the UK variant and the other variants that are arising. Next slide, please. So just looking at the results, and I want to really just compare these. The adaptive, we see the current course kind of model, we see a peak in late February of about 50,000 cases per week. Next slide, please. This is the fatigue control scenario, kind of the worst case scenario with the pessimistic vaccine. You see gradually increasing case numbers. Peaking in early May. I do want to note how kind of thin that peak is, and then just look at the shape of really the Northern Virginia area there, how it's kind of a gradual increase, a quick peak, and then a rapid decline. I just want to compare that to the variant one, which is next. So next slide, please. So this peak is with the new variant. This uses the adaptive model, the current course model, and then adds that new variant scenario onto it. The peak isn't much higher. It's about 75,000 cases. It occurs a little earlier, the exact peak, but it is a very flat peak. So we remain above 65,000 cases per week for 10 total weeks from February 21st to April 25th. In this scenario, and I do want to take a look at the shape of Northern Virginia there. I need to dig in with the UVA team about the reason for that, but it seems that we have a substantial number of cases, particularly in Northern Virginia, for a long period of time. Next slide, please. So this just kind of combines what I showed in the previous charts. You can see the comparison of the projections, the different scenarios in the chart on the right, and then just summarize the numbers there. Next slide, please. This is titled Adaptive Fatigue Control, but I'm actually showing the hospital demand and capacity by region using the new variant scenario. So you can see most areas, they remain pretty good as far as bed capacity is concerned, using that rule of thumb of 80% for when we'll feel pressure and 120% where hospitals might be able to increase capacity. But in Northern Virginia, we do see that those large numbers for a sustained period do show us Northern Virginia breaching that 120% level. Next slide, please. And this is, of course, where you can find the modeling results. Everything will be updated at the end of this call. Thank you. And I will check the chat for questions.
Thank you, Justin, for the update. Next up, we'll move to the testing update with Suzanne Trotter. Susie, can you please take the call?
Yes, I'm on. Thank you. Next slide, please. I'll just give you all a quick review of where our testing locations are. It's just a hit to the VDH website and then share a little bit about our expansion into Walgreens. Next slide. So we've had a few questions throughout the time this week and the past couple of weeks. Where can I find testing locations? So just a reminder to locate that on our VDH website. On the main page, the bar that you need is COVID-19 data and resources, but the link is there on the slide if you want to go directly to COVID-19 testing. And the two icons there, one is a clipboard with a cross. That's just all about testing, but it's the indicator of location is the one you need to hit, which says COVID-19 testing sites. And in the next slide, I'll show you an example of the filtering capacity. You can filter by your location anywhere that you are, put in your zip code or your city. It can search a radius 50 miles around you and give you up to 200 results. And if you see the boxes below, you have a choice by locality, you have a choice by drive up through testing, rapid, etc. And in the next slide, I did an example specifically for Blacksburg. I typed in Blacksburg, did the default 50-mile radius, and 26 sites came up for free testing. I had checked the toggle indicative of free. And as you see the little asterisk below, it's primarily available for those who are uninsured, underinsured, Medicare or Medicaid. So just an example of the locations that surround Blacksburg. I believe in the next slide then, I also did another, just an example. This time I picked Waynesboro, same default 50-mile radius. And this time I chose pediatric. So 28 sites populated within a 50-mile radius for pediatrics. Again, the asterisks below may have some age restrictions and additional criteria. So as always, please contact the testing site. But wanted to get you back to those filters, the toggles, because this continues to grow and has significantly grown since we started the testing. Next slide. As a caveat, this map and what is populated is only what we know. There are more testing sampling sites. There are more continually coming on, especially with our pharmacy partners. So as always, guide people to reach out and call their providers and pharmacies and other providers. But this is one filtering site you can use. Next slide. Below the filtering on where locations are is our weekly upcoming testing events. So just as a reminder, you can scroll down on the page and see the dates, the locations, the address of where community testing events are occurring. Next slide. And last but not least, wanted to share as far as it goes with antigen Binax Now cards that we have. We do have a new survey to order Binax Now antigen cards for our community partners. Chris Patterson will put that link in the chat. So for anyone who wants to get more antigen cards and meets the criteria, you'll be able to refer them to the link. What's on the screen right now is the press release that went out on the 14th about the expansion. The link is there on the slide as well. So we have a public-private partnership with Walgreens. Our initial outline was to look at vulnerable populations and where there was low testing resources, and chose the original 15 in partnership with Walgreens. All 15 are open now, and if you go to the next slide, not only in the press release will you see the addresses, but they are all listed here. They are free. This is our state's Binax Now cards in partnership with Walgreens to get them out to the communities. There is an appointment step to make at these Walgreens, and the link is there, walgreens.com COVID-19 testing. But again, it's free. If the client has any difficulty or challenges, Walgreens has assured that you can call. The client can call the store manager or the pharmacy and ask for assistance with that COVID-19 testing and the registration, and say they don't have a computer or they're having transportation challenges. So wanted to share this list of 15. We are currently looking at our Tier 1 and Tier 2, which means the next set, using our funding sources from the federal grants that we're receiving. We're looking at continuing expansion to throw out a broader net. So just wanted to update you all. This came out recently. Wanted to be sure that you had access to this for clients in your area that may be best benefited by utilizing these Walgreens resources. And that's it for today, I believe. I stand by for any questions you may have.
Thank you, Susie. At this time, we will have question and answers continue in the chat box. If you joined by WebEx, please type any questions for presenters in the chat box. If you've joined the meeting on phone, please email your questions to donald.moore@vdh.virginia.gov with the subject line LHD call question, and we'll forward it to the appropriate parties for answer. At this time, if you feel that you want to drop off the call, feel free to. I'll leave the chat box up and the call open for about the next 15 minutes or so, unless I start seeing that there's no questions coming through, at which time we'll close out the meeting. Thank you, everyone, and have a great weekend.